Hi, my name's Andrew and I'm a haematologist, and today we're going to be talking about massive transfusion in the context of critical bleeding. What is critical bleeding? What is a massive transfusion, and when do we use them, and what makes this area so complicated? So we'll talk about massive transfusion, we'll talk a bit about critical bleeding, and we'll also use a clinical case to help us understand why this is important. And so if you're a health professional, or particularly someone that works in one of those health supporting roles, like in a laboratory with haematology or transfusion or biochemistry, this talk is very much relevant for you. Let's talk about Rupert. Rupert was involved in a car accident, a really common reason for people to come to hospital with trauma-related injuries. He's brought by ambulance after the car accident. He's unconscious throughout the retrieval and at the time that he's at the hospital. In case you don't know, not every hospital is appropriate for trauma. If you're in a rural setting, you'll go to almost any hospital to get assessed and stabilised and then retrieved to the city. But if you're in the city, there are some hospitals that are marked as trauma hospitals, and they often have a full range of trauma, cardiothoracic and neurosurgery services, as well as an intensive care and theatre and anaesthetics that are going to support managing such complicated and acute patients. Initially, we see that his heart rate is elevated at 138, his blood pressure is low at 86/42. These are signs that there is hemodynamic compromise occurring, and it may be that the patient is going to shock. His oxygen saturations are also reduced, not severely so, but definitely not as they should be at 87%. They should be above 96. Initial bloods show that the hemoglobin is severely low at 56, and the white cells are mildly elevated, a sign of inflammation, and the platelets are also moderately reduced at 89. He has a number of scans done, and a CT of his brain confirms a subdural hematoma and a splenic rupture with a large volume of intra-abdominal hemorrhage, as well as pulmonary contusions, which are probably responsible for his decreased oxygen saturation. So Rupert's not in a really good place, and we have patients like this coming to our trauma centres every day of the week at all hours of the day. Let's just try and break down the issues around his case right now. So Rupert, in terms of his clinical assessment, is probably suffering from hemorrhagic shock, where the body is struggling to manage with the acute amount of blood loss and volume loss due to his splenic rupture primarily, as well as the hematoma in his brain. He also has type 1 respiratory failure, and that's probably related to the contusions and inflammation in his lungs from the trauma. He also has active intra-abdominal bleeding, and that's probably the highest risk to his life at this point and needs to be addressed before most other things. He also has what seems to be an inactive intracerebral bleed, which is likely responsible for the fact that he's unconscious, but will need to be managed after the abdominal bleed. And then he seems to have acute severe anemia because of his blood loss, and that also is life-threatening and needs to be addressed. So let's think about how do we, if the clinical team, address Rupert's needs. He's going to need an addressing of his hypovolemia, that's a low amount of volume of blood that he has at the moment, with fluids, and also probably with vasopressors. So they're drugs a little bit like adrenaline that will help increase his blood pressure despite the lack of volume, and that can be offered in intensive care, emergency and in theatres. We need to address the severe anemia with transfusions of red cells, as well as probably platelets and some other blood products to ensure that he doesn't clot inappropriately or not enough. We need to stop his intra-abdominal bleeding, and we're probably going to need emergency surgery to achieve that. We also need to address his respiratory failure with ventilatory support. We need to bring his oxygen saturations up, and it will be normal to intubate someone for theatre, especially if they're already unconscious. And then lastly, we need to think about his subdural bleed and how we're going to ensure that doesn't do any further damage to his brain and his body. So running through what happens to him over the next 48 hours, he receives 4 packs of red cells, 2 packs of fresh frozen plasma, and 1 pack of platelets as part of a massive transfusion pack. This is a universal donor unmatched, so we don't have time in his case to go through the half an hour to an hour of matching and finding appropriate products. So we order a massive transfusion pack and to save his life essentially and get him ready for surgery. He's intubated, sedated, and put on a ventilation or life support machine in the emergency department, and then that's continued in theatre. Blood pressure and the oxygenation improve with these initial resuscitation measures, which is great. And that makes him stable enough to go to theatre, where a trauma surgery team perform a laparotomy, that is to say open abdominal surgery, and they remove the entire spleen to prevent further blood loss and clean up the blood that is inside the abdomen. After theatre, we can see his hemoglobin, despite the red cell transfusions, has increased to 75, and that's still not really a desirable number. And his platelets have dropped further, probably because of blood loss again, to 45. We can also see that he is developing a coagulopathy. He has a raised international normalized ratio of 2.1 and a raised partial thrombin time of 50. His fibrinogen is also low at 0.9. These signs to me suggest that he may be going into disseminated intravascular coagulopathy or a trauma-related coagulopathy, both of which are quite a significant threat to his well-being and will cause more complications if not managed appropriately. He's transferred to intensive care after starting in emergency, going to theatre, and then he comes to intensive care. There he receives 2 more packs of red cells, 2 packs of platelets, and 2 packs of fresh frozen plasma, as well as cryoprecipitate, which is basically a concentrated version of fibrinogen. 12 hours later, despite his initial management, he neurologically deteriorates, and the CT shows that the initially stable subdural hematoma is actually enlarging. So neurosurgery take him to theatre and evacuate that hematoma, eventually going in surgically to take out that blood so it doesn't put any more pressure on the brain. And after that, Rupert receives an ongoing improvement and is able to eventually leave the hospital to rehab. But you can see how these things happen very quickly, and massive transfusions is very much needed to address critical bleeding in partnership with surgical and other services. So let's talk a little bit about critical bleeding and massive transfusion. We define critical bleeding as being a hemorrhage or bleed of a small volume but in a critical area, and this is classically within the skull. So an intracerebral hemorrhage, there is not very much space in there, so even a small bleed can be critical in terms of life-threatening to the patient. But otherwise, if there's a hemorrhage elsewhere, it's a major hemorrhage that is life-threatening. And so in this case of Rupert, his hemoglobin dropped significantly and he developed hemorrhagic shock. Both the hemoglobin drop and the hemorrhagic shock would easily put him in a category of critical bleeding. And you can see from the graph that I've got displayed here, this is packed red blood cells. So this is units of red blood cells that are transfused within 24 hours. Unsurprisingly, the higher amount of blood that is transfused in the first day, the higher the mortality related to the patient, because the bleed is so severe, it is increasingly life-threatening. And those that are only requiring small amounts of red cell transfusion will naturally do better, and that's usually a sign not about the transfusion, but that the bleed itself or the cause of the bleed is more easily managed and is not as life-threatening as the others. A massive transfusion, there's a few different definitions around, and there's probably not one agreed one across the country and across the world, but the ones that we generally go for in guidelines and in literature are a transfusion of more than 1 blood volume in 24 hours. And if you take an average of a 75 kilo patient, that's about 10 units of red cells or the equivalent amount of blood within 24 hours. Also, you can define it as being a transfusion of half of 1 blood volume within 4 hours. And there's some other definitions you'll find out there that are related to 6 hours or 12 hours, but I find those two to be the most helpful. Massive transfusions are generally specific to particular surgical teams who deal with patients that have vascular structures or bleeding or trauma that will require emergency surgery and require enormous amounts of transfusion to keep the patient alive whilst the bleeding is being dealt with. So classically, they're cardiothoracic surgery, whether emergency or elective, trauma, as we saw in the case of Rupert, other surgery, gastrointestinal bleeding, which is often dealt by gastroenterologists in endoscopic means, but also surgeons, vascular surgeons, and most commonly that's going to be a abdominal aortic aneurysm that may have ruptured or be operated on, and that can lose a lot of blood very quickly. Then there's, these are the lesser ones, but obstetrics, so postpartum hemorrhage, so after giving birth having bleeding, can be a life-threatening event. Liver transplants, it's a very vascular organ. And then there can be things that are combinations of vascular and trauma and cardiothoracic and neurosurgery that are combinations. And the last one is medical patients, which is what I usually deal with. They don't usually have large bleeding or require massive transfusions, so it's pretty rare. Every time that we're actually giving blood product and every time we're losing blood and replacing it with fluid, all these different blood products, we're actually diluting the total amount of coagulation factors that are inside the blood. So it's not just that we're losing red cells, platelets, and white cells, that's the easy one to remember, but at the same time, we're losing the same amount of plasma, and the contents of the plasma being albumin and clotting factors are the ones that we're particularly interested in. As we lose them, they go into a coagulopathic state, generally that they're more likely to bleed excessively, and that can add to an already uncontrolled hemorrhage. And you can see here a table that as we lose more blood volumes, coagulopathy that develops is more severe, and the residual coagulation factors, if we don't intentionally replace them through fresh frozen plasma and other means, will drop all the way down to 5% by the time that you've replaced it 3 times the blood volume. That's a really dangerous place to be. So whenever you have hemorrhagic shock, and that's a response of the body to a large hemorrhage, there's a number of issues that can occur for the patient that further threaten their life and well-being and cause complications. So one of them is hypoperfusion, that is a lack of oxygenation to cause appropriate metabolic activity in the tissues, and that will usually be related to a low volume state and the acute anemia. So not only is there not enough blood, but the blood that is there has a low amount of hemoglobin, can't carry the oxygen and other glucose and the like to the tissues. So then you get vasoconstriction, a compensation of the body to maximize the amount of blood that's there to try and maintain perfusion to the critical organs like the brain and the heart and the kidneys. And then that also will result in a compensatory metabolic acidosis and low blood pressure because you're no longer having appropriate circulation, and so the periphery will start becoming colder and hypothermic. That in itself can cause problems and can worsen coagulopathy. So then with hemorrhagic shock, you can develop this lethal triad, which is a combination of acidosis, hypothermia, which we've mentioned, and the coagulopathy, which we've also mentioned. And that combination can worsen bleeding and worsen organ damage related to already the hemorrhage. And then as those complications develop, the later consequences can be things like damage to the kidneys, which is renal injury, a systemic inflammatory response syndrome or SIRS, which we see more commonly in intensive care, hepatic impairment from hypoperfusion injuries, gut ischemia, which can be life-threatening, and bone marrow suppression, so that you're not actually compensating with the production that is needed in those acute situations. Let's talk a bit about the actual products that we're giving, and I'm going to assume that you have some basic understanding that we can transfuse red cells or packed red cells, platelets, and then also fresh frozen plasma and some other more specific factors. And just thinking specifically about the red cells, platelets, and the fresh frozen plasma, one of the things to realize is that the units that we're using across the world are very similar. However, in the case of platelets, 1 Australian pack of platelets is generally considered to be the same as 4 packs in some other countries. So if you're looking for ratios and wondering why we're using less platelets, it's because it's equivalent to 4. So if you were to give a pack of red cells, a pack of platelets, and a fresh frozen plasma, the total amount of volume there is about 650 mils. And you can see that it's returning about 62% equivalent of the coagulation factors needed in blood. That's sufficient for healthy clotting, but can easily be quickly consumed, and it's certainly not the 100%. And you can see the platelet concentration is decent, but not the same as the physiological amount in blood. We generally consider the optimum ratio of products to be given is 1 pack of red cells to 1 pack of platelets to 1 pack of fresh frozen plasma unit. And that will give roughly a healthy amount of blood replacement in severe hemorrhagic states. And generally, we will give this as an empirical amount when we don't know how much blood loss there has been, and if there's ongoing blood loss, we should just give empiric therapy with this 1:1:1 ratio, bearing in mind that the 1:1:1 ratio is based on the international version of platelets. And so you'll see that generally you're giving 1 pack of platelets to every 4 or 5 packs of red cells. We'll come to that in a minute. And then after some time, generally once we've got more testing, once the hemorrhage is either controlled or lessened, we think about individualized therapy. And this is where, based on complete blood examination, coagulation testing, and sometimes viscoelastic testing, which I'll mention a bit later, we can customize the blood products that are used for the specific patient. And so that is usually a better way to go once the initial acute hemorrhage has been dealt with. So a massive transfusion pack is generally a universal donor pack, and that's different for plasma versus red and platelets, unmatched blood products, and they're ready to go in a cooler. So most transfusion centers will have a cool pack ready with red cells, and they'll have platelets and fresh frozen plasma thawed and ready to be put into that pack within minutes, so that pack is ready to go to emergency or theatre or intensive care, wherever it needs to be, so that you can transfuse a patient within minutes of calling from that pack. We generally see these packs going to the emergency department and operating theatres, and rarely anywhere else. And the contents will vary by different hospital location. And even on the national guidelines, they give recommended amounts, but it's up to each hospital and generally their haematology department in partnership with trauma, intensive care, ED, and anaesthetics to work out exactly what they think is the best amount of product to include. So some examples of hospitals that I've worked at and national guidelines. Hospital G, you can see, has 5 packs of red cells, 3 packs of plasma, 1 pack of platelets. Remember, 1 pack of platelets is like 4. Then in Hospital H, same 5 packs of red cells, but they've actually met that with the same amount, 5 packs of plasma, 1 pack of platelets, and they also include 1 pack of cryoprecipitate there to meet the needs of fibrinogen deficiency. And then another hospital might have 4 packs of red cells, 2 packs of plasma, and 1 pack of platelets without the cryo. So you can see there's variability, but they're roughly similar amounts of product that are there. And there are some hospital protocols that the first pack will have these certain contents, and the subsequent packs for the same patients will actually include extra plasma or an extra pack of platelets, because the need, based on their statistics, is that they need more plasma at that point. So whenever we give a transfusion, and this is particularly important when we give multiple transfusions, the risk of complications and the other products inside that bag can become more clinically significant for the patient. So thinking about red cells, the red cells can contain a relatively low pH compared to the body's pH, a high potassium compared to the body's potassium, and additional iron. And the iron's probably a good thing because most of the time we're giving it for blood loss, so the iron's fine, but we need to know that when we're transfusing multiple packs, we are actually causing, through the transfusion, a increase in the acidity because of that low pH that will transfer into the blood and will contribute to an acidosis in the body. And that can then cause coagulopathy. Also, we could cause a hyperkalemic state, a high potassium state, if we're giving multiple transfusions, and that needs to be dealt with as well. Whenever we're giving fluid, you'd think that's pretty benign, but every bit of fluid is diluting the rest of the blood products that are there. Sometimes that's necessary. And if you're giving normal saline, we've got to be aware that this can contribute to a hyperchloremic acidosis. And if you add that to the acidosis that is contributed by the red cells, you're getting a more significant acidosis as you go along. Lastly, fresh frozen plasma and platelets contain relatively little potassium, so they can actually contribute to a low potassium state. These things we're not always aware of because we just think they contain the one set of cells, but the fluid that they come in also contains these other hidden contents. It's also important to realise, though these products are provided free in Australia to patients and hospitals through the Red Cross Lifeblood Service, which is a national, under the National Blood Authority that governs these products, the actual cost to the community is quite significant. They cost a lot more than most medications and interventions that we provide in hospital. So roughly, for every pack of red cells, we're really paying as a community about $1,000 if you think about the advertising and the administration of recruitment of donors, hopefully like yourself, who then donate the blood. The blood is then transported and refrigerated, it is processed and refined, it is tested to make sure there's no infections, it is tested for what blood type and antibodies it contains, it then is stored for a period of time, it is transported to a hospital and then provided to a patient. And not all products will get used, some of them will expire unused. And so the cost of all of that for red cells is about $1,000 today. Roughly for platelets it's cheaper at about $500, and fresh frozen plasma sits about halfway in between those two, around $750. And then there are more expensive specific factors, the most expensive being Nova 7, which is activated factor 7. That is a surprisingly $1,000 per milligram, and some trauma patients might need Nova 7, as well as some specific factor deficient patients, and they might be using anywhere between 5 and 10 milligrams per time. So that dose is pretty significant, and the cost to the community is great. Apart from the contents of those products, we're always at risk of having transfusion complications. And again, the risk is there even for a single product, but as you add multiple products in a massive transfusion or critical bleeding situation, the risk of those complications developing is much, much greater, and they need to be monitored for and managed specifically in a more intentional way. So one of them, naturally, the more blood product you're given, the more your risk of circulatory overload. So that's just the pure amount of fluid that's being given to a lot of these patients in order to resuscitate and save their life can cause a transfusion-associated circulatory overload, which is TACO. You also can get an inflammatory response in the lungs, which is called transfusion-related acute lung injury, and that usually happens quite acutely, and we need to manage that in intensive care generally. Also, every time that you give even an appropriately matched product, there is a risk that there'll be an allergic reaction, most commonly a febrile non-hemolytic reaction, but there are other allergic reactions that can occur there. Then you can have more formal hemolytic reactions where antibodies or mismatching of specific antigens with their antibodies can cause hemolysis. And then so the blood that you're giving to address anemia then actually contributes to the anemia rather than solving it. You also run a small risk every time that you transfuse products, particularly platelets being the highest risk, that you may transfer an infection from that donor's blood into the bloodstream of the patient, usually bacterial but sometimes viral. And even through the best and most robust testing processes, we can't fully exclude that every product has a potential small amount of bacteria in it that could cause an infection. Fortunately, that's very rare in Australia. Lastly, the amount of red cells in particular and plasma that you transfuse into a patient increases their amount of allo-antibodies that may not be a problem now, but may be a problem later when it comes to needing some form of stem cell or solid organ transplant, and also can develop a refractoriness to platelet transfusion. So that's usually a long-term issue rather than a short-term. Sometimes in the midst of transfusion, critical bleeding and massive transfusion, we can use other products to try and improve the coagulopathic state and reduce the amount of bleeding. And one of them that's commonly used, particularly in trauma, is tranexamic acid. If you're not as familiar with hemostasis, there's primary and secondary hemostasis, and then there's fibrinolysis, where plasmin will break down the fibrin and dissolve clots. And most of the time in someone that's bleeding critically, we don't want to break down the clots, and so we can give tranexamic acid to help slow the rate of deterioration of that clot by preventing the activation of plasmin and therefore preventing fibrinolysis. So that's a relatively benign and pretty safe product to give, which is good in a peri-op setting, and is particularly good if given within the first few hours of trauma. Lastly, we have other testing beyond coagulation testing and beyond the complete blood examination, which is viscoelastic testing, which is either TEG or rotational, which is ROTEM. In my hospitals, we use ROTEM. And this is used to evaluate the different stages of clot formation and dissolution, and provides a more specific and real-time analysis of the clotting in a patient, more than traditional coagulation factors can provide. The other benefit is that the ROTEM can be done in a matter of minutes, whilst even in a very efficient laboratory, coagulation studies usually take a minimum of 45 minutes and can take sometimes more than an hour if the lab is very busy. We've got different assays within the ROTEM that are run that will help us account for different dynamics, and these are XTEM, which is the external pathway, so they tell us more about platelets and fibrinogen. You've got the FibTEM that specifically looks at fibrinogen activity. You've got the INTEM, which is the intrinsic pathway, and you've got HepTEM that can deactivate heparin and then compare to the INTEM if you think that heparin might be interfering with the assay. The turnaround time there is literally 5 to 10 minutes, so it's done often in intensive care or laboratory or in theatres to give a rapid result that can be acted on immediately, and time is blood and time can be life in these patients, so it's really valuable. Overall, we've proven that using ROTEM will generally decrease the total amount of products that are given to a patient, and therefore you're reducing the total amount of complications or the risk of complications from that transfusion. So ROTEM can be a good thing, and there is gradually more and more studies done in different surgical and trauma and other patients that are generally showing that we can improve mortality outcomes, as in people can live more if their transfusion strategy is guided by ROTEM rather than traditional testing. So there's more research to be done and better understanding to know the role of viscoelastic testing, but this is actually a really positive move forward in terms of technology, and I'm excited to see where this will lead in the coming years. So if we take a step back and look at managing critical bleeding generally, you can see that a critical bleeding patient needs a very broad group of interdisciplinary specialists and clinicians to be involved. The paramedics, in emergency, there are emergency specialists and nurses, anaesthetists, trauma surgeons, theatre nurses, neurosurgeons, radiologists and radiographers to get us the imaging to guide surgical intervention. Haematologists often are involved with coagulopathy, intensive care specialists, intensive care nurses, pharmacists to look at medications and pharmacology, and allied health staff to ensure that people get a good recovery. And then indirectly are all these really vital support staff that are working hard in the background. They can be haematology technicians and scientists that are doing ROTEM, coagulation testing, complete blood examinations, and ensuring that we're getting a high quality, efficient result back to guide the clinician's decision making. Biochemistry technicians and scientists looking at the function of different organs, again to guide management. transfusion technicians and scientists to ensure that there's the right matched blood available efficiently, the preparation, the storage of products, and organising to make sure the right amount of blood is available in the hospital every time of day and that we're not short, which can happen through the year. And then lastly, we've got the lifeblood staff that are really managing the collection from the community, the processing, storage and distribution of blood products to meet the needs of our patients in hospital and the outpatient setting. So when you've got a critical bleeding patient, the strategy is to look at the different factors that are contributing to the harm of that patient and addressing them. So if they've got a penetrating or blunt trauma injury, it is likely they'll need urgent surgery. Anemia, we set a target and we continue monitor and we transfuse red cells to meet that target. Similarly with thrombocytopenia, we set a target and we continue to transfuse platelets to meet that target, particularly in the first 48 hours and around the time of surgery. If we've got a coagulopathy with extended INR, prothrombin time, or partial thrombin time, we think about correction with fresh frozen plasma and sometimes prothrombinetics and other specific factors. We can correct hypofibrinogenemia, which is detected on viscoelastic testing or coagulation studies with cryoprecipitate or sometimes with artificial concentrated fibrinogen to reduce the risk of transfusion overload. And then there are more metabolic issues like low calcium, which can contribute to coagulopathy, can be corrected with intravenous calcium. Metabolic acidosis can be dealt with reperfusion, bicarbonate, and sometimes dialysis. Hypothermia with external warming and blood warming devices, and coagulopathy that might be dealt with other specific factors. So you can see these patients are complicated, but with good care, we can get good outcomes and have the patient walk out of the hospital in the end. I hope this will be helpful, and we'll see you again soon.